Ladies and gentlemen, thank you very much for giving me the opportunity to present the results of my study today. As you can see here, we want to present the results of the 5-year study we did on percutaneous needle fasciotomy and fasciectomy. I have no financial interest to disclose. The purpose of this study is to compare PNF and LF in a randomized controlled fashion because the increasing interest of patients for a short recovery period and minimal invasive treatments. We also already did a pilot on PNF, and we proved that short-term results are quite nice, especially in lower Tubiana grades, grades 1 and 2, and they're quite comparable to LF results. So we wondered, is this also true for a long-term outcome? From August 2002 until January 2005, every patient who presented to our department was considered for this study. Patients were asked to fill out the forms. They had to have a flexion contracture of at least 30 degrees in PIP, DIP or MCP joint, and they had to have a clearly defined cord of the palmar fascia. And of course they had to be willing to participate in this trial. Many patients had a special treatment wish, and that is one of the exclusion criteria. As you can see, also patients who had post-surgical recurrence or extension of the disease were excluded, as well as patients who were not allowed to stop their anticoagulants or generally unfit for surgery. Well, preoperatively we recorded patient demographics, such as age, nationality, diabetes, epilepsy, and such. We also recorded the TPD, which is the total passive extension deficit, measured on the DIP, PIP, and MCP joint, the DASH score, and we asked patients 10 questions about satisfaction. Well, then we randomly assigned patients by pulling an envelope, which said PNF or LF, and patients were treated within 1 month by one of the senior authors. LF was performed on a regional or general anesthesia using a Skook incision in the palmar area and a Brenner incision in the finger. Excision was done used loop magnification. We transposed the skin and sutured it, and patients got a bandage for 1 week and explicit instructions to practice flexion and extension in the bandage. PNF, can you please start my video clip? I hope it works. It's quite a large video. What you were supposed to see here is quite like the other presenter before me showed. On the local anesthesia, you punch with an orange needle, which is the smallest needle, the cord, give a passive extension to the finger, crack the cord, and then that's the procedure. Follow-up. Every patient was seen 1 week post-operatively, 6 weeks post-operatively, after 6 months, and then yearly until 5-year follow-up was completed. Whenever recurrence or extension occurred, patients would fall out of the study, and the study was terminated for that patient. Post-operatively, we would measure TPD, patient satisfaction, hand function, recovery, and whether there was extension or recurrence. In this study, we defined a recurrence as a worsening of TPD of 30 degrees compared to the post-operative measurements at 6 weeks, because in an earlier study, we proved that after 6 weeks, the best results were obtained. For statistics, we used the chi-square tests for categorical data, students' t-tests for recurrence and patient satisfaction, and Kaplan-Meier survival curves, and we used linear by linear association for age versus recurrence. The results were, we treated 115 hands in 111 patients. 95 of them were male, and 17 were female. They were equally divided over both groups, as well as the mean age. We had a little bit older patients than previous presentations. Maybe patients come to our department a little bit later. The mean age was 63 years, and they were also equally divided over both groups. 54 patients were treated by LF and 61 by PNF. In the LF group, we lost 11 hands. 32 of the remaining had no recurrence, which is 74%. 11 patients had recurrence, and recurrence occurred after a mean of 3.8 years, with a standard deviation of 1.1. In the PNF group, we lost 7 patients, 7 hands. 46 hands showed recurrence, which is a recurrence rate of 85%. 8 hands only showed no recurrence, and recurrence occurred earlier after 2.1 years. Well, I put it in a table so you can see very clearly the difference. You can see here that PNF is occurring much more often, but also much sooner. And we also use statistics to prove this. And the p-values, as you can see, are very small. Recurrence in the LF group was significantly smaller, and in the PNF group occurred sooner. Well, to prove our results, we also did an analysis on the worst and best case situations, because you don't know whether the patients who we lost had a recurrence or not. As you can see here, I presumed that every patient we lost had a recurrence, and then you can see here the difference between PNF and LF. So we presumed that every patient lost had a recurrence, and still the difference is very large. And we also did a best case analysis. In this case, you can see the difference is getting even bigger. Well, then this is maybe a little bit hard to read table, but we tried, oh, I see, I did this in Dutch. We tried to do an analysis of age versus recurrence, and what you can see here, you have the green and the blue bar charts. The green one is the PNF, or is the non-recurrence, and the blue one is which patients have recurrence, and you see the difference is getting smaller when the age gets higher. So what you can see here is the age. We put it in groups, and the eldest patients, so they are more elder than 75 years, they have more non-recurrent disease than recurrent disease, whereas in the younger patients, they all get recurrent disease. So I'll explain a little bit later what we prove here. Then we looked at the treatment of recurrences. After PNF, 25 patients chose to have another go at the PNF, and in the LF group, 4 patients chose to undergo PNF, because we let the patients choose, obviously. Then in the LF group, the recurrences were, after PNF, 7 patients chose to have LF, and after LF, no patients chose to have another go. So, and there were also 12 patients in the PNF group that didn't want any treatment, whereas in the LF group, 7 patients not undergone any secondary treatment. Well, then we asked the patients, are you satisfied with the treatment? They could give marks from none, not at all, and they would say 0 or 10, which would be excellent. And we also asked the patients, would you choose this treatment again? Well, in the LF group, as you can see here, patients were really satisfied with the results and also said they would choose it again. And in the PNF group, patients were also quite satisfied and also said they would choose it again, but the p-values are statistically different. And maybe you wonder why they say they are so satisfied and would do it again but didn't. That's because this is the whole group and not the only patients who had a recurrence. So in conclusion, recurrences are far more frequent after PNF. Recurrences also occur sooner after PNF. Overall satisfaction is high, but higher after LF than after PNF. And many patients chose PNF as a secondary treatment anyway, in spite of the above. Recurrences happen in young patients more frequently, no matter what treatment. So what can we do with the results of this study? Well, I think PNF is suitable for patients who require fast recovery of hand function, who are willing to accept early recurrence. And PNF is less suitable for younger patients because they already have a bigger chance of getting a recurrence. So maybe we can better save this treatment for elder patients because they have less chance of getting a recurrence anyway. We also think that a PNF should be reserved for a clearly defined cohort. This was the end of my presentation. Thank you very much.